Okay, let's continue. Next question, we have a 62-year female with diverticulitis who underwent laparotomy for a sealed diverticular perforation. 16 days post-operatively, she developed fever, leukocytosis with some pseudopurulent discharge from the surgical site. She was on empirical cefoperazone sulbactam since 5 days, after which her symptoms resolved completely. The culture of the pus shows scanty growth of enterococcus fecalis susceptible to your ampicillin, amoxicillin, amoxiclav, vancomycin, linezolid, HLG, etc. So what would you like to do now? So change to ampicillin, switch to ampi plus genta, stop CFS, escalate to meropenem. So let's revisit this case. Patient is having diverticulitis, underwent laparotomy. She had some fever, leukocytosis, purulent discharge, but her symptoms have now resolved completely on cefoperazone sulbactam. And culture of the pus has scanty growth of E. fecalis. Again, your gut is one of the your commensal. E. fecalis is one of the commensal of your gut flora. So if the patient's symptoms has resolved completely and the patient is having scanty growth and there is no other indication, so we need to stop the CFS. As escalation to meropenem obviously is wrong, because even if you are trying to cover enterococcus, your meropenem does not have any cover for your enterococcus. Ampigenta, obviously no. The only place where we'll be using ampigenta is when you're especially suspecting infective endocarditis or any severe enterococcus infection, which this patient profile does not seem to fit. Change to ampicillin, again it is not required in this patient. Next question. So a 47-year male presents with end-stage renal disease was on maintenance hemodialysis 3 times a week with an HD catheter placed in the right internal jugular vein. He complained of fever with chills post-dialysis from past 2 weeks, for which he got tablet cefixime. But his fever persisted and is having now severe lower back pain. On examination, you note some purulence in the HD catheter site. The blood cultures were sent, which shows growth of MSSA, which is sensitive to your linezolid, vancomycin, clindamycin. The patient has had multiple access failure and your nephrologist is keen to preserve the line. So read the following statements. The HD catheter has to be removed. Investigate for the further metastatic spread. In view of difficult access, HD catheter may be replaced over the guide wire by a new catheter at the same site. Appropriate culture-based antibiotic systematically and an antibiotic lock therapy to salvage the catheter. So, as I mentioned before, CLABSI, whenever a patient is having CLABSI with obvious purulence and your blood culture is showing, especially staph, your any GNB, Candida, these are the ideal candidates where source control in terms of removal of the catheter must be done. So, this catheter has to be removed. This is correct. Now, if you see, revisit, the patient is having severe back pain, so which can be a component of the metastatic spread of the MSSA, which is staph is notorious for. So, whenever you're seeing staph in blood, we have to not discard it. You cannot discard it anyway. So you have to rule out endocarditis, rule out any metastatic spread by doing either MRI or PET scan. This could be spondylodiscitis. So we have to investigate for the metastatic spread. HD catheter replaced over, so there is obvious purulence. So if you place the catheter over the same site, obviously it will get infected again. And appropriate salvage therapy, antibiotic salvage therapy can be tried if the patient is having cons, if the enterococcus band, there is no other option. But again, this therapy, the success is limited, and also there are the limitations, like once you have put the antibiotic lock therapy, you will have to not use that catheter for up to 24 hours. So it is difficult to do. So how will you manage this case? It is combination of 1 and 2. So A is the correct answer. Next, a 30-year male presents with fever, sore throat for 5 days. On examination, there is tender cervical lymphadenopathy, HB is normal, platelet is normal, WP is slightly raised with some band forms. Which of the following is most unlikely? So whenever a patient presents with fever plus sore throat plus cervical lymphadenopathy, what will be your differential? So especially in this age group, so your first and foremost will be your infectious mononucleosis. Then we have infectious mononucleosis mimics also can be there, where like it could be your toxo, CMV. Then we have diphtheria. So there is currently the increasing incidence of diphtheria. Then they obviously gas, that is group A streptococcal infections, and one more important thing which should be remembered is ARS, that is acute retroviral syndrome, can also present with such. So it's tender. So whenever you look for tender cervical lymphadenopathy, you will always look for infective cause rather than a lymphoma. So most unlikely in this situation is lymphocytic lymphoma. Next, which of the following statement is correct about post-splenectomy infection? So as we all know, spleen is one of the site for where the capsulated organisms are removed. So whenever spleen is removed, we need to protect the individual. So by doing what? Vaccination against your capsulated organisms like pneumococcal, meningococcal, Haemophilus influenza, hip vaccine. Then we have to also have give them influenza, regular influenza, annual influenza vaccination, antibiotic prophylaxis. All splenectomized patients should take for first few years at least, and high risk patient will be on lifelong prophylaxis. Initially it was penicillin, and again this antibiotic is it is covering basically these organisms, but because of the increasing resistance to penicillin, the current recommendation is to give amoxicillin and not I'm telling amoxicillin and not amoxiclav. And then also emergency, the patient should have high antibiotics. So whenever they are experiencing any fever and chills, they should take antibiotic appropriately, basically to prevent the overwhelming sepsis. Next question. So which of the following statements is true with regard to UTI in post-renal transplant patients? Asymptomatic bacteriuria requires no treatment in renal recipients. Routine screening for UTI with periodic urine cultures 2, 4, 8, 12 weeks is not recommended. Complicated UTI requires a treatment of 14 to 21 days. More than 6 incidents of UTI is called recurrent UTI. So let's look at this. So this is taken from American Journal of Transplantation, UTI in solid organ transplant. So coming to the definition, so what they were first as recurrent UTI is 3 more than equal to 3 episodes and not 12 episodes, 6 episodes. Next, when you look at the treatment, so asymptomatic bacteriuria in especially renal transplant is always a dicey situation. They can be treated for first 3 months, for treatment for 5 to 7 days, and after 3 months avoid the treatment unless it is associated with raising creatinine. Next, for treatment of mild infection, oral therapy for 5 to 7 days, moderately severe 14 days, very severe we have to consider 14 to 21 days of therapy. Next, screening. So do you have to screen that 6-12 months? So whenever we are doing a screening strategy, we can recommend up to routine collection of urine cultures for up to 1 to 3 months after renal transplant. Thereafter, there is no necessity to screen them as well. So coming to these options here, so asymptomatic bacteriuria requires no treatment is not correct. First 3 months you are going to treat them. Next, routine screening of UTI, it is recommended for at least 3 months. Then complicated UTI, this is the correct one. Recurrent UTI is more than 3 episodes. Next, recent change in the CLSI 2023 are all except. So recently, so the CLSI has revised. The first major change is change from A, B, C, U, O, I, that is grouping into tier system 1, 2, 3, U, O, I. So this tier system is based on first line, second line, third antibiotic. So all of these should be tested together but reported according to the susceptibility. Revision of the breakpoint for peptides has again occurred for enterobacteriales as well as pseudomonas. For enterobacteriales, it has become 16, 32 and 64, that is susceptible SDD as well as resistant. Then one more important change is with amikacin breakpoints. It has been changed for enterobacteriales, aminoglycoside breakpoint for enterobacteriales as well as pseudomonas. There is a change in breakpoint, but important thing is for pseudomonas they have removed the breakpoint for amikacin, but for non-urine isolates they have removed. Urine isolates they have still retained the breakpoints for pseudomonas with amikacin. They have totally removed the breakpoints for your gentamicin. So option C is correct. Next, as per AWARE classification, vancomycin belongs to which group? So what is this AWARE? This is given by the WHO. A stands for axis, W stands for WA stands for watch, and RE for reserve. So axis is the antibiotics which are the first line antibiotics which can be accessible to all, which contains amoxicillin, ampicillin, amoxiclav, etc. Watch, that is restricted. Here we have to restrict the use of these drugs in routine practice. So if you see vancomycin, it is in the watch group. Reserve is the antibiotics which we have to use judiciously for MDR infection. So these includes newer antibiotics like polymyxin, colistin, linezolid, ceftazidime, avibactam, etc. Next, so organism in critical priority in Indian pathogen priority list. So just like the WHO, Indian ICMR also has come up with the Indian pathogen priority list, which includes critical priority, high priority and medium priority. In critical priority we have CRE, colistin resistant enterobacteriales, as well as in non-NFGNB we have Acinetobacter as well as Pseudomonas, which is carbapenem and colistin resistant. High priority we have your MRSA, H-Visa, daptomycin non-susceptible, enterococcus, VRE, linezolid resistant, daptomycin non-susceptible, salmonella, which is third generation non-susceptible, carbapenem resistant, and your azithromycin non-susceptible. So if you look at this question, critical priority, all of these, which of the organism comes? It is the CRE. Next question. A patient received oral trimethoprim 200 mg BD for 7 days. The WHO DDD, that is defined daily dose for oral trimoxazole, is 0.4 gram. So what is the DDD? So what is DDD? It stands for defined daily dose. It is the assumed average maintenance dose per day for a drug used for its main indication in the adults. So basically this is DDD is used in adults. So one DDD is what is the DDD? It is assessed and given as per the ATC code and the route of administration. So when you are collecting number of DDDs is equal to therapeutic dose into the grams per tablet by the WHO DDD. So we have 200 mg BD. So that was we will convert to mg to gram, because the code is the given is 0.4 gram. So 0.2 plus 0.2, that is 0.4 given over 7 days divided by the WHO defined DDD, that is 0.4. So the answer is 7.